Hi, sorry. We have about 15 minutes of discussion, so I'd love to hear some from webcast as well as here.
Okay. Hi, again, Christy Arnold from Year Up, Inc., NCR, the site here. My question actually is regarding, because you mentioned quite a bit about cultural competency as it relates to health, and just thinking about race-related stress, and particularly one of the things that I found in research that I actually did when I was in graduate school on racial microaggressions. And it really talked about the fact that there is this notion that individuals of color experience these very covert things that may be said at work or at school or in certain environments, and they are kind of left with the task of, was that something said that I thought was offensive? Or, oh no, maybe I'm just being a little paranoid and I'm making too much out of it. Or, you know, well, he or she has said that 2 or 3 times now, and I'm now starting to wonder if there's something there. So I found that a lot of, I found a minimal research, but it was really interesting to me that tons of this racial microaggression that goes on starts to play out in the health and the well-being of someone, because it certainly starts to play on the psyche and just your overall mental and emotional well-being, which, as you said, it's all connected, that once the mental health and the emotional health become affected or impacted, it starts to trickle down into the physical. So I didn't know if you've heard anything about it, or if that's something that you'd be interested in looking into as well.
Thank you for that comment and question. No, I would be very interested in looking at it, and there's been a variety of work that actually has looked at that, and in fact the IOM document on unequal treatment goes into that as well. And there's some other interesting work that is like a corollary of that also. It's not just kind of what you perceive people are saying, but what people perceive you and who they perceive you to be. We had a wonderful talk at the Society of Adolescent Health and Medicine where a woman from the CDC, her first name is Camara, I'm blanking on her last name, Camara Jones, yeah, talked about the fact that the way you're perceived, so there were fair-skinned Latinos and fair-skinned black people who were perceived to be white, and their health outcomes were actually better because of the provider's perception, irregardless about how they felt about themselves. And those people who perceived themselves to be people of color actually had worse outcomes. So it's all very interesting in that not only is it about kind of how you feel about yourself, that clearly, I mean, there are biological things that happen when you get stressed or you get angry related to a circumstance, but it's also related to what how someone perceives you to be, irregardless of how you think you are.
Was there a webcast question?
There is, thank you. So our webcast audience member would like to know, what are the low-hanging fruit opportunities for research or intervention development to improve young adults' physical health? And this was for both panelists.
The low fruit. Well, there's one answer. There are probably multiple answers, but certainly you were talking about vaccines. If you're talking about interventions that are very evidence-based, that can really get to things, if you could get young adults who have one of the worst immunization rates of almost everything, if you could get them vaccinated against flu and pertussis and HPV and other vaccines, you will prevent a lot of morbidity and mortality that is cost effective. The other one, it's more tongue-in-cheek. I was going to mention that because we were talking about that cauldron, and what is the kid that gets thrown in there and then comes out great, that is resilient to that. I mean, if we were able to find the antigen that does resilient personality and could make a vaccine out of that, that would solve a lot of problems, but I think that's far away. But I'll let you answer that, yeah.
Well, my answer actually wouldn't be very different from Dr. Neinstein's, which is why I kind of had it in my summary. The vaccine issue has so much potential and potential in ways, as I've mentioned, that no medical innovation has actually been able to achieve. And so when we think about vaccines now and the potential to eradicate not only cervical cancer, but anal cancer and vulvar cancer or vaginal cancer, or certainly to decrease those rates and actually decrease health disparities, as well as genital warts. I mean, it's the most common sexually transmitted infection. But even things that like hepatitis B that also have hepatocellular cancer. So I I would clearly, definitely have vaccines way up on high. And I think the other thing that where we agree is that I think we need more information about resiliency. Again, the majority of young adults make it through and make it through fine, even those who have particular challenges. What is it that they have? What is that? What are those resiliency factors? And so part of that is, again, as I had mentioned, trying to do more research on resiliency factors and protective factors and harnessing that energy. And not a low-hanging fruit, but one thing I think would be really important is trying to make sure that all young people have access to health care.
And one quick thing about resiliency. There was a great article a while back called The Victorious Personality, and these kids that did well. And they found two things, one internal, one external. The external was really a involved, warm parent, as Larry Steinberg talks in his stuff about parenting. The internal was a little harder to gather out. It is something resilient, but it was harder to kind of define and transmit. But I think that we really do need significant research in creating the victorious personality.
My name is Juan Jose Callejas. I work with Latin American Youth Center in Washington, D.C. I have a very quick question. Do you have any data related to so-called the immigrant paradox, or any sources of data talking about resiliency, especially with groups that are under tremendous assault sometimes nationally and locally? Thank you.
So there is lots of work, I think, in process, but it's clearly not where we want it to be. And I think the other thing that makes it complicated, as complicated, if not more, than looking at other populations, is we talk about these groups as if they represent one group. And so for Latinos, we're talking about people from Latin America. We're talking about several different countries within Latin America who have different cultures and different values. And so while I believe that there is some work to be, and then there's this whole issue of, immigration and what that does, and, it's such a complicated issue, and we've tended to, some of the research to look at it really on the surface. There clearly is much more that needs to be done, and so I would do a disservice to try to give it broad brush strokes.
There is an interesting thing. This isn't to do with Latino. It has to do with actually a Chinese population and immunizations. When Affordable Care Act came into place and all of our students could get free HPV, no copay, no deductible, we can't keep HPV in stock. We've been ordering 15 or 20,000 every couple of weeks. But the largest group to come in is the Chinese population. And somehow, because it's harder to get available there, there's a network that discusses it, and they can't talk as well to their parents about it. They have really been drawn to getting HPV. So it's been quite amazing to see. I wish they could just talk to all the other students on campus.
Bonnie?
Hi, Bonnie Halpern-Felcher from the University of California, San Francisco. Larry, Leslie, Tamara, thank you so much for a great presentation and great discussion. I want to, a quick comment leading to a question. One of the populations I don't think you mentioned or thinking about was geography, and particularly looking at rural youth. And that leads me into the comment, which is also, then leads to a question, which is that, when we talk about access to care, we've talked a lot about the individual and the young adult, but there's also the access to care piece, and part of it is great. We've got the ACA, and we've got a lot of great things going for access to care, but it doesn't mean that the individual also wants to go access care or feels comfortable in that situation. And the reason why I was thinking about rural youth is a lot of times young people want to get reproductive health care or something else, but they can't because the providers don't want to provide it, or they've got conservative values in their areas, or whatever the disparities are that is going on is a cultural disparity, or sometimes some of the work we've looked at is generational gaps between the younger and the older providers. So just given that, the NIH has really been trying to push the pipeline idea of getting greater populations into the healthcare system, so getting more racial ethnic minorities, more diversity in that. So just a comment on, do you think that's the easy solution, or do we need other education to really get the receptacles for these young people to go to?
Thank you for that question. It's excellent. And as you recall, when I put up the list of, how people are diverse, I said it wasn't 100% complete because we can think of so many ways to segregate ourselves or separate ourselves, if we will, with the challenges. But rural is actually really important. And I've had some really interesting experiences with young adult populations in rural areas that I would not have even thought of. So we in North Carolina have part of the western part of our state is the Appalachian Mountains. And so we were going to be working with the Center for Rural Health Innovation to actually do a project, a school-based health project that not only dealt with adolescents but young adults. And we encountered things that we took for granted, like when we finally got up the hill and into the mountain, cell phone use went off. We talked to the reporter, and she's, writing it by hand. And she was telling us that she has one of the few internet connections, and it's dial-up. So the intervention that we were going to use with telemedicine and social media really wasn't going to work. And so we actually did, we did some community assessments, and we actually did get a telemedicine network to go through Tennessee, and everyone said that they wanted to do it. And then we went to go implement it. People actually really didn't want to do it. And there were issues about privacy. Who's on the other end of that? Who am I talking to? I can't see that person. And so one of the things that's real important to me, and I've alluded to that before, is that whenever you're going into whatever community it is, whether it's a rural community, whether it's an LGBT community, whatever that unique special population is, and when I say special, I mean special in a good way, engage them as much as you can in the process of, not what do you think about this, but how would you do it? How would this best meet your needs? Because it'll often be different than what you think.
Trina?
Hi, I'm Trina Anglin. As we've been listening to various presentations, I wanted to ask a question that is always on the top of my mind. Having previously been a healthcare provider of adolescents and always trying to be really, really comprehensive in what I've done, I also recognized that there was kind of a marginalization between the actual healthcare community and all of the other resources available in the community for young people, such as youth development programs. And I know that, through the emergency room, that programs such as TED's Healing Hurt People, and that's really a hospital-based program, but perhaps there could be some connections between that and primary care practices. So with the Affordable Care Act, and and hoping that all young people, as well as everybody else in our country, ends up with a medical home, and trying to be really comprehensive, we also know that the healthcare system certainly could not do it all. And so I'm wondering, are there any models that anybody is aware of that perhaps have been studied that really look at the connections between what goes on in the healthcare home, or the medical home for young people, and referrals to community organizations and to evidence-based programs? So for example, if a healthcare provider were to identify a young person who perhaps was engaged in gangs, would that healthcare provider be able to refer that person to a gang reduction program, or to a program that really could help around the symptoms of trauma? And conversely, for young people who are in community programs who probably are at risk for a variety of health issues, what is the connections that a community program can make to the to healthcare providers within that geographic community? And if those connections are established, kind of going back and forth, how can that be studied, to be able to assure better health and safety outcomes for our young adults?
Trina, it's a great question and an important one, and it's why I kind of put that circle up there with community, because that is so critical. And one of my pet peeves about internal medicine residencies, at least when I was there, is that you'd get somebody admitted at 8 o'clock at night, and you'd have to present them wrapped in a ribbon at 8 o'clock in the morning. Their whole life, 50, 60, 70 years, all wrapped up and decided, and get them just polished off and off. And life is not like that, and it doesn't revolve around whether it's a physician, a psychologist, a physician assistant. It is a whole community of people that that are required that can collaborate and intervene. And I think it's critical that as we move that way, that we really find those connections, and they're different for different people. And we have to find what is it for that person, because for that person it could be the church. Their church could be the most important place where they're going to find their community and get help and get them together. It could be, athletics. It could be Cub Scouts. It could be many different things. But we've got to get that program and new programs. And then I guess, it is always about, how do we evaluate it and make sure that it's working, and that becomes a critical component, because getting the grid that you could say, okay, I have this person with this, and where is it leading me to that intervention would be great.
There is one program that I'm aware of that has had a national evaluation, primarily dealing with young people and their decrease in their risk of violence-related behavior and educational attainment. And that's the national evaluation of the Big Brothers Big Sisters program. And it does kind of what Larry says, is, you have a one-on-one individual, but there's some caveats. One, the person has to, the mentor has to be with that person for 2 years, so it can't be a 1-year, interaction, and have regular contact, which is basically, you went with them with the majority of the activities. But it's a very tailor-made activity so that the mentor actually looks for those social supports and things that are important to that young person, whether it's, getting them involved in community activities, getting them actually into, the healthcare system. But that's one of well-evaluated and substantiated evidence-based program from a community perspective that interfaces with the healthcare system and has good outcomes.
Do we have time for?
Sure. So Sarah from our webcast audience submitted this comment. Resiliency data would require longitudinal data to know A, what factors existed prior to or concurrent with the entry into adulthood, and B, outcomes. When, that is later into adulthood or into middle adulthood, would you expect to see that resilience, and what outcomes would you suggest we look at? That was long.
That's not a 2-second question. She's absolutely right. It would require longitudinal data. There is a longitudinal data set called the AdHealth, but again, you'd want something that even preceded adolescence. And so my hope would be that if the National Children's Study ever kind of gets fully underway, there are many, many things that are in there in terms of covariates, like not things that you might not even thinking about, but like looking at environmental exposures, where people live. So I can't really answer your question because we don't know. So what we really need to do is to look at as many different factors as we can, kind of maternal diets, We don't really know what those things are going to be, but if the National Children's Study ever comes forth, we'll hopefully be able to hone down on what some of those things are.
I think you're right. Although I would bet if you followed these people longitudinally, if you took people that had the resilient gene and you took people that had the resilient network or person that was in their life, I will bet you they will respond better throughout life. It doesn't mean they won't have traumas. It doesn't mean that they will have issues. But I will bet you that they will respond better.
I have a question and I guess 2 points. My name is Luis Cardona. I'm from the Montgomery County Department of Health and Human Services, and I direct all violence prevention and violence intervention programs. I kind of noticed that Dr. Beasley touched on the issue of diversity, and you talked about resiliency, but I'm kind of interested in particular, not just because of your presentation, but pretty much what I haven't heard all day, and that was the protective factor of culture and how it plays a major role in resiliency. I'm very familiar with how we use it as a tool in working with, in particular, communities of color. And I'm kind of interested in as to why there's been no mention of that. And that's my first question.
Probably the 15-minute time limit, which I went way over. But you're absolutely right. There are certain protective factors related to culture, and one of those has to do particularly with people of color whose families prepare them for their journey in the world by talking about racism, by talking about what they're encountering, so that, or what they may encounter, so that when it comes, they're not completely surprised. And there actually has been some research recently that looked at young people of color compared with whites and their resiliency as it related to encountering discrimination. Because again, you can be white and experience discrimination too if you happen to be disabled or poor. So those individuals, when compared to people from racial groups, didn't do quite as well. So that protective community, that protective understanding of racism and belief that racism and discrimination exists was actually a protective factor for those individuals compared to people who did not have those experiences. So you're absolutely right. Culture can be very protective, and particularly when that culture is ingrained in the community where you live.
You know, I just wanted to add to that, to your response too. If anyone gets a chance, while it kind of focuses on the Latino community, but I would venture to say that I believe it overlaps into so many communities. If you get a chance, there's a document that was written last summer by a gentleman by the name of Jerry Theo with the National Compadre Network, and it's called the Brown Paper, okay? And so it hits a lot of this stuff on the nose, and I'm very familiar with it because a lot of my programs that I have in place train all my staff and all my grantees in these type of evidence-based trauma-informed curriculums. So I just wanted to throw that out there. Along the lines of what the young lady had asked about before, I want to ask, since there's so many doctors in here. I administer a number of grants, and one of the newer initiatives that we've been implementing in Montgomery County over the last, I would say, 5 years, with the establishments of these high school wellness centers. Now, traditionally, they've been really focused on somatic health. What we did is, we combined the positive youth development components, and even to the extent that, as I've written RFPs for the programs, I've now challenged a lot of the vendors or whoever's going to do the work to kind of consider going beyond being just trauma-informed, but kind of doing things in the sense of what Dr. Corbin was talking about at Drexel, right? And so my question is, and I think it's connected to what you were asking about, because I've been thinking about this all day with the Affordable Health Care Act, and now the possibility in Montgomery County, and I hope I don't get myself in trouble with, that we're going to expand both our school-based health centers and our wellness centers so they become hubs in the community where not just the students in those schools get those services, but their families as well as the rest of the community. So my question is, could we perhaps be looking at the opportunity to come with a very systematic response to what all of us have been talking about with this model that I just talked about, in the sense that we would now have, youngsters who would get all those supports, mental health services, youth development, case management, all the somatic health that you can think of. But now, as we expand and they access not just somatic health but behavioral health services, that it can kind of become a continuum, because that's our vision. And my question to you is, do you believe that it can address a lot of these things that you're talking about? I'm talking to anybody in here that wants to answer that question.
Okay. I think that's a phenomenal idea, and that's actually what we had to do out west in Appalachia. In order to get the kids engaged, we actually had to get the families engaged. And what a great way to kind of reinforce the health behaviors that you want, particularly because in that area, there were a lot of young adults who were still living with their families because the economy there was really bad and there weren't a lot of work opportunities. So when you think about obesity prevention, who's cooking the meals? Mom's cooking the meals. When you're thinking about physical activity, group activities are reinforced when you're doing it with multiple people. So you have the opportunity to reinforce health among communities. And I also think it can be a really great access point for people who are young adults, because where do they go? If they aren't in college, there's no college health center for them to go to. If they're not in school but don't have money, where can they go? And that would be a perfect place in the community that also integrates physical health with the fact that it's also important for educational development.
I've always been a very strong proponent of school-based health clinics, but that they should be broader than just the medical. Wellness is a difficult term because it's not the best term. There's probably, but I don't know that the English language has a better term. And if anybody has a better term in another language, let me know. But it also has to be focused on what the community needs, because it could mean different things in different places. And so you really have to know what your population is and work on that.
Thank you.
I was corrected on the term. The term is full-service schools.
So
Thank you.
this has been a pretty exciting conversation. Thank you for staying so attentive. I think one of the things that's come out of it is, you know, the health side really needs to be connected. When I think it's Dr. Sestersten talked about the interconnectedness of the world, and we need to get back to that. All these questions and what people are talking about is talking about being interconnected, and health isn't somehow separate from the rest of the community. Thank you so much. I think we have a break till...
We're going to have a 5-minute leg stretch dance, and then we're going to start again at 3:35.
So 3:35. Thank you.